Good morning, everyone. My name is John Hooksma, I'm publisher of Digital Health. Welcome to the keynote session on our AI and analytics stage. And wow, it's great to see so many of you here for a brand new show. And we know from our registration data that 70% of you are new audience that we've not seen at a digital health event before. A really eclectic mix of data scientists, analysts, NHS professionals, startups, researchers. Welcome to you all. We have a great kind of opening session for you on the AI and analytics stage. And in this, we're going to be looking at different facets of AI's transformative role within the NHS. Three very different, great speakers, and they are Dom Cushman, who's Director of AI Imaging and Deployment, NHS England. It's my good fortune to know Dom well, and can I say this is a small miracle we have Dom here, who's usually pulled out into meetings at seconds notice. I'm absolutely thrilled to welcome Dr. Catherine Halliday, who's President of the Royal College of Radiologists. No Royal College is more at the forefront in adoption of AI and the issues around it than the Royal College of Radiologists. And also absolutely thrilled to welcome Dr. Stefan Zoran, who's the Associate Professor of Engineering Science at University of Oxford, a man who knows AI better than almost anyone else in the room, including fascinating topics such as time stamping, which I'm still struggling to get my head around a little bit, but Stefan's going to put that all right very shortly. I'll be chairing. We're looking for lots of interactivity in the session, and this session is made possible through the support of our headline sponsor, Fathom. So without further ado, I'll ask you to put your hands together for our three speakers. And welcome Dom up to the mic.
So I'm going to do the first slide, which has to be done in every presentation. Look, the key thing I want to say here is that AI has been in pop culture for over 100 years. And in terms of scientific literature, has been around for decades. And, you know, if we think of even the author of Jurassic Park, Michael Crichton, he got his doctorate at Harvard University in 1960s, who ended up building out some really interesting computer science models based on how you predict some diseases. And that's kind of played into some of the kind of early activities. I found this on my bookshelf the other day. I don't know if anybody remembers the Usborne books of, it's not a pop-up book. I'm not going to be doing a bedtime reading story for you, but it just reminded me of like the early parts of the 1960s and the 1970s. We were really excited in the future of the tomorrow. And it reminded me of like, what was it that we were predicting, what we were going to have when it came to artificial intelligence to support medicine? And were we going to have these little robots going around to help us? I'll leave that up to your own imagination. And especially with the leading of the summit happening this week, led by government, it's going to be quite interesting to see how we have this conversation around artificial intelligence in all our various parts of public life. I'm going to do a helicopter view of all the activities that are currently happening across government and then give you a flavour as to what's happening for us in the NHS AI lab. So the first thing to note is that back in 2021, government announced the National AI Strategy. Can I get a show of hands of everybody that has read that document and give a yellow highlighter? Great, quite a few of you have got some bedtime reading to do. And then from there, we had a number of different exercises in supporting what is it that we're doing with our regulatory marketplace, and what are we doing to support both industry, academia, and research. And a couple of key things, these are just highlights of activities that are worth reading. One, which is the pro-innovation approach to AI regulation, which supports how are we thinking about innovation and AI. What are we doing with medical device regulations? And what are we doing when it comes to supporting AI as software as a medical device? Can I get a show of hands of all of you who have been sat diligently reading the software as a medical device regulations? Oh, wow. Okay, great. Fantastic. Lots of great questions going to be coming up then. And in that roadmap, we have a number of items where we're supporting how we're thinking about biases in data sets, what we're doing around adversarial attacks, and what are we doing to make sure that we're getting the best practice out of AI. And also in collaboration with the FDA and the Canadian Health Agency, the MHRA have worked diligently at an international level to support good machine learning practices, and that's being played into a number of different activities that we'll see kind of play out throughout the rest of this week. The other thing to note for those of us who are interested in post-market surveillance is the new latest material on predetermined change control plans for machine learning enabled medical devices. Highly recommend people to have a read of that, talking about how we think about when the actual product changes. It's an exam question that we come up with on a regular basis. When does the product actually change when you've changed the actual inputs that inform its outputs? So I'm just going to come straight to this slide. The NHS AI Lab was set up in 2019. For those of us who have been around, its entire raison d'etre is basically around safety, safety, safety. Our entire goal is to support the adoption of safe, effective, and ethical AI. We talk about removing the hype and getting to the realities of what it is that we'd like to see deployed. We have a number of different mechanisms that we do in this space to make sure that we're both collaborative but also engaging in the technical side. The key things to note is things that we're thinking about when it comes to ethics. How do we support the big ethical questions that we all face when it comes to machine learning and its practice in healthcare? And a couple of references I'm going to play out. By all means, take screenshots of this and have to take Q&A. Is we partnered with a number of different civil institutions, Ada Lovelace, and including the UKRI, ScienceWise, to do two pieces of work with us. One about how do we make decisions about access to data, and how do we think about data stewardship. We've also recently, this week, announced the program of work called Standing Together, which is an international Delphi, looking at how do we standardize data sets, as led through the University of Birmingham. We've been very key thinking about what are the type of things that we all want to see in terms of the data sets when it comes to training those algorithms specifically. Not the most glamorous activity, but regulation is one of the key foundations to getting all of this work done. We've been very proud to work with our partners at all the different agencies, both to support NICE in updating its Everett Standards Framework, also supporting and working now with NHS resolutions, looking at the exam question that we face around legal liabilities of AI in clinical settings, and we're doing a 3 to 6 month piece of work looking at what does that actually look like. I'm going to talk a little bit about the AI Regulation Service. You'll hear more of that throughout the week from colleagues across the agencies. But ultimately, it's a cross-regulatory exercise working with the various agencies, the MHRA, NICE, the CQC, and the HRA, and all the various other agencies involved to support a single point of contact under AI Regulation Service on the NHS website. So you can go and find the information that you need as a developer, but also as a commissioner if you're thinking about building or purchasing these products. A couple of other helicopter things before I hand over to Kath is that we have a number of other exercises which Kath will talk about in partnership with the RCR. We're doing something called the AI Deployment Platform, looking at the policy recommendations of how do we think about AI integration into the clinical setting, working closely with two large imaging networks. And also quite recently, the AI Diagnostic Fund, which is a £21 million ring-fence fund, I'm happy to take questions on as well. I'm going to leave it there and open it up to Kath, please, to talk a little bit more. Thank you.
I'm going to just start this introduction. I am president of the RCR, and we have a particular interest in this area. Of all the Royal Colleges, we are particularly interested. But I am also a jobbing radiologist. And so my interest is primarily a clinical one. How can this help? How can technology help us help our patients deal with the huge numbers of cases that we have to review? Let me tell you a tiny little bit about the RCR. The RCR has getting on for 16,000 members now. We have radiologists and clinical oncologists in our college, and so both of these groups are using AI quite a lot now, or definitely at the forefront. So for those of you who aren't medical, radiologists use medical imaging to diagnose and treat things, and clinical oncologists treat cancer with radiotherapy, immunotherapy, and chemotherapy. So why are we looking at AI in this area? There's a huge amount of attention, particularly in radiology, in this at the moment. Absolutely innumerable companies, algorithms. How do we make sense of that? How do I, as a clinical director in my hospital, make any sense of that? It's definitely got massive potential to increase accuracy, efficiency, and actually, above all, to improve patient outcomes. All of these things we need. We definitely need efficiency. We're really struggling to keep up. And actually, our outcomes for many conditions, most notably cancer, are much worse than other countries in Europe. So we need help. But what we need to ensure is that we don't rush into it. We ensure that we maximize our benefits and avoid harms. So what's happening at the moment in diagnostics? It is a bit of a Wild West in terms of enthusiasts are implementing algorithms in their trusts. I think it's safe to say. There are many, many products, as I've mentioned, and actually we don't know where or what people are deploying. So nobody does really at the moment. So I'm going to come on to what we're doing about that, but we hugely welcome, first of all, the AI Lab's work on regulation, which is so helpful because it's completely daunting for the average person what to do. So this is really, really helpful to streamline and make that digestible for the ordinary person. And also the AI Diagnostics Fund, recently announced and awarded, where a number of trusts, a number of networks will be deploying AI across their network. And because they're all doing that together, because we can form a community then and understand what the barriers are, and also really, really look at the benefits. What are the benefits? Are they what we think they are? And also, what about safety? What do we need to do? This is hugely helpful. Similarly, the AI deployment platform will be looking across 2 different networks about the best way to deploy different algorithms across that in this cloud-based solution, which will help us deploy algorithms at scale. And that is obviously what we want. So these are really, really helpful pilots, and we've got to make sure that we get as much information as possible. Coming to people who aren't within that, within the RCR, we're developing an AI imaging registry, and you'll be able to, if you are deploying AI in your trust, please do register, or if you are a company who is deploying in a trust, please do register your product. That will be opening soon. The data collection is just starting with a few people, but in November, I think anybody will be able to register. And that way, hopefully, we'll have a comprehensive idea of who's deploying what across the country. And that'll enable people to have a community to support each other, for one thing, understand what's going on, and form a basis for audit. And generally, this will be extremely helpful. So another thing that we have done at the RCR is look at the barriers to implementation. I was a clinical director before I was elected as president of the RCR, and I did try to start a trial of an AI algorithm, which I thought would be really helpful in my trust. I tried for about 18 months to get this. I couldn't get beyond the GDPR, the procurement. It was impossible for me. And so we held a day where we got a lot of people together from industry, from NHS, just jobbing radiologists, and looked at what the main problems were. The main problem at that stage, people were identifying, was information governance. It's very complicated. Nobody's got any headspace for it. Lack of evidence, actually. Is it actually going to help? IT infrastructure. Well, I'm sure it won't be a surprise to anyone in this audience that IT infrastructure in the NHS could do with a little bit of improving. And generally capacity. And of course funding. So that's why the AI Deployment Fund has been so helpful. So we came out with a list of possible solutions here. And I think what I'd like to concentrate a little bit is about looking at what we need to do to give people confidence. And I think these new projects will be really, really helpful with that. We actually don't know what the benefits are. We assume it's going to save us time, and we assume it's going to improve patient outcomes. But of course, when you change something in a system, in a complex system, you may have unexpected consequences. So we need to prove that. And we need to use these opportunities to gather that data. We also need to understand what the steps are beyond regulation and pre-deployment. What are the steps to actually getting it going into a clinical pathway? What do we need? And I think we're going to need secure data environments, and we're also going to need to understand about shadow mode and about how you deploy in your trust. We're working very much with the NICE early value assessments, and that's been very, very helpful in terms of chest X-ray, and they're looking at various other areas as well to actually assess what evidence there is out there and what evidence needs to be collected. So I think that's really helpful, and actually that tailors very, very well with the Diagnostics Fund. So I've mentioned that, and I've also mentioned the deployment platform. So what we need to move on to now is that looking at the workforce, what do we actually need to enable us to move forward on these developments? Particularly, and it's not just about clinical staff, there are very few IT staff in trusts have enough headspace to help with new projects like this. And so we need to enable people to have the headspace and the expertise as well. And we need to understand how people can be retained. Oh, it's not moving forward. Oh, yeah, sorry. Yeah, I know, it's not. Well, just talk amongst yourselves. No problem. You see, I'm a technological genius, as must be obvious. Okay, so what actually do we need to understand? So when we get an algorithm, we need to know it's been tested, it's got results. We need to know whether it's been tested on a population which is similar to our own. You know, if it works in Sweden, does it necessarily work in Nottingham? Not necessarily. So we need to understand that. We also need to understand, will it work in our IT environment? So will it, you know, it may work perfectly in the lab, but it doesn't necessarily work in the complexities of our NHS IT situation. And we also need to do some longer term audit. So we need to look at, will it be actually exacerbating health inequalities? This is something we really need to understand, and depends very much on how it's been tested and how it's used. And so longer term audit is also needed. So we need pre-deployment testing with secure data environments. We need to understand shadow mode, and we also need regular testing after deployment, and then we need long-term audit to look at health inequality. So all of those things are things that we need to look at and we need to get in place in order to understand and reassure people that this actually is safe. So at the moment, we have a lot of developers telling us in a way what it is that we want. So we need to change that around. So as clinicians are now driving the market a little bit, saying, well, you know, actually this is what we need. This is the thing we need help with. So we definitely need to improve that link too. So where are we now? As I say, there's huge interest in investment, and the areas that we need to work on are shaping the tools that are available, moving that pathway from regulation to implementation, quality assurance, audit, and of course, education and training. In my ideal world, I see that we have eventually an AI assessment or audit unit where we guide people through these processes and are able to look at new developments and reassure people and gather the evidence we need. So that is a very simple person's idea of the future. Thank you.
Thank you.
Thank you, Kath.
Thank you, Catherine. Hold those questions for the Q&A. And next up, I'd like to invite Dr. Stefan Zoran, who's the Associate Professor of Engineering Science, University of Oxford. Stefan.
Thank you. Good morning and welcome everyone at AI and Data here at Digital Health. So my name is Stefan Zoran. As mentioned, I'm Associate Professor at the University of Oxford. I've also worked for a couple of years with the Turing Institute, the National Institute for AI and Data Science. And I'm also associated with the Oxford Internet Institute, which does a lot of work in AI ethics. But besides that, I'm also a co-founder of Fathom, who is the headline sponsor here. And I wanted to take an opportunity to showcase you some of the work and some of the outcomes we have been doing at Fathom, but also to link it up with some of the more state-of-the-art academic work I have been doing at the university, and how it is useful to maybe look a little bit more under the hood to create some more bespoke solution using some of the more state-of-the-art methods. So Fathom was kind of born out of the desire to create a company which utilizes AI and data-driven approaches to improve patient outcomes, but also to improve efficiencies in the NHS, which I think is quite important, as we've seen as well with some of the comments on certification. It's quite useful to have also applications which do not necessarily require medical device certifications. Now, speaking of birth, I think one interesting example I wanted to mention out of the topics we worked at Fathom is that of EDD, our expected due date project. And what was quite interesting, I personally had a child recently, and you are given this kind of traditional estimate of when your child is due to be born. If you are coming from a statistical background like me, you would be amazed that those estimates are actually biased. So it couldn't be any worse from a statistical sense, even giving like the average estimate calculated over a number of patients will give you a better estimate. So what we did, we took a whole large data set of patient data, tens of thousands of records of patients giving birth, with hundreds of observations taken during the first months, anything from measurements in ultrasound skills as well as other background, and we use this to make better prediction of the expected due date. And we actually get quite good results there. So if you know a little bit technically, R squared, so the traditional estimates actually have negative R squared because they are biased estimates, and then with some simple models you get 20%. Our models are twice as good, and we can have several applications of this. One, for example, is the idea of having a flag for premature birth, and we are quite good with a very low recall. We actually get precisions of 88% of flagging early on patients which are at the risk of being premature. Besides those outcomes for individual patients, it's also quite interesting that you can take all these results and you can aggregate them to come up with estimates of patient flow. What is actually the number of patients we expect this weekend? How many births? How many C-sections? And that can be used again to plan ahead and kind of optimize efficiency. And this is, I think, a very interesting area to apply AI, and something which is easily overlooked. Let's just make sure that we have enough beds before we look into treating cancer using AI. So it's a very important topic, and I also refer to our stand for you to learn a little bit more. The same techniques can also then be applied, the ideas of patient flow, not just in maternity, but other applications as well. For example, emergency departments is one where you would really like to digitalize as early as possible all the incoming information and try to make predictions. Patients coming in on an ambulance some might be released the next hours, other ones might be staying multiple days in intensive care. So having early prediction is quite useful to kind of plan ahead the process. So those were the two briefly the two examples I wanted to mention, and I refer you to our stand to learn a little bit more about the details of the approaches and the results. But I also wanted to connect a little bit to how do we actually utilize some of the state-of-the-art machine learning techniques in building those models. And we have heard in the first talk that AI has been around for many years, that is true, but it has been especially over the last decade that we have seen this exponential growth of capabilities of machine learning methods. And I think two domains where this has been very much obvious is image recognition, and we already heard about image recognition in the previous talk. Another one is natural language processing, where we have seen huge advantages. And what I want to do in the following, to give a little twist to the story, I want to actually explain you how some of these large language models work, but I actually don't want to apply those techniques to textual data, but I just want to use the techniques underpinning those models and apply them to different, more numerical data to make predictions. So over the last decade, we have seen tremendous increases. People might have heard about Word2Vec, which came out exactly 10 years ago. BERT was another model, but the most popular and most famous one I think everyone has heard about is ChatGPT, which came out last year. And there has been a lot about hype, but one question we might ask, what does a GPT actually stand for, and what can we actually learn from it by looking a little bit more into detail in the meaning? So GPT means generative pre-trained transformer. Generative and pre-trained are quite easy to understand. Generative means I ask it a question and then it generates an answer. That's the kind of essence of this word. Pre-trained means this model was trained on a massive corpus of data, and then using the trained model we can now apply it in a multitude of situations. The last one is a more interesting word, and it might be one of those science fiction books which we have seen in the first talks, the transformer, and it is quite interesting to actually understand how those transformers work. So the basic idea of the transformer is actually to make another technique called attention more computationally efficient. So attention is just a computationally efficient way of using attention, and attention is a way where we try to learn the meaning of words by attending to other words. The very, very old word models, they just looked at the word like a vector in a vector space. Then some other ones looked at the neighboring words to try to figure out the context. Now attention can actually learn weights between one word and different other words and extend it over potentially very far distances in the same document to learn really very complex meaning of sentences. And then once you have done it, you can now use those models pre-trained on large sets of data, and then you can apply them in different domains. You can kind of fine-tune them on different applications, such as, for example, sentiment classification. And just to give you some example of how this idea of attention works, here are two sentences. The patient's results were positive, and the patient had a positive outlook on their recovery. Both contain the word positive, and very early sentiment analysis models would have said, okay, there's also all positive sentences, but we know that the way the word positive appears is different in those contexts. Because here, for example, in the first one, positive really refers to results or patient's results, which is the same as laboratory results. So that can actually be something negative. Maybe the test on cancer came back positive, whereas the second one, positive, refers to recovery. So it's a positive or positive outlook in recovery. And this is exactly how those attention models work. And by creating these links and being able to even refer to words a few sentences backwards, they try to get a really good understanding of sentences. This is just to give you some intuition. You might have heard about ChatGPT, but how does it actually work under the hood? The interesting thing is, once you know how the models work, you can also apply similar techniques in other domains. So the one is text, which is the one we all know, we have all on our phone. I can ask questions like, what are the symptoms for sepsis? And I will get the answer right away back. But there are other domains as well, and those are actually the ones where I work on in my academic life. One is actually time series. So you can apply the same transformer techniques to time series. So rather than ingesting words, it actually ingests numbers. It could be temperature observations, economic data, blood pressure readings. You read in those numbers, and then you try to make predictions rolling forward maybe one step or multiple steps into the future, or signaling that something is wrong. And the model can pay attention to very interesting aspects of the data. It might go now back in the economic model and point back, pay attention to the last economic crisis, seeing that things are going to go wrong. And similarly, in medical context, it might pay attention to some moments where maybe clinical data is deteriorating quickly, and by this, get a much better understanding of the medical situation. Similarly, like the textual models got a very good understanding of the sentences, here we can get very good understanding of numerical data. And you can even do more and combine numerical data and text data, for example. This is actually some academic work which we did at the university, where we looked at COVID-19 caseloads, and we have time series data of previous observations of caseloads, but we also complement it with textual data from social media where people post, oh, I have a fever, where can I find more paracetamol? And we don't just use the textual information, and we don't just use the numerical data, we use everything together, which gives us the best prediction. Just the textual data will give us a good estimate of what the caseloads be. If we hadn't had the numerical data, for example, in an African country, we don't have observation, we could get a good guess of the number of caseloads. But actually, if we have some numerical data over the last weeks, combining the two will give us the best estimates. And this is where I think really a lot of power exists, by kind of looking a little bit more under the hood, taking those latest state-of-the-art models, but applying them to time series, applying them to observation, blood pressure, heart rate, rather than just being restricted to the textual domain and to the areas where we have had a lot of hype on, and kind of applying such of these state-of-the-art techniques which are bespoke, and applying it in a bespoke manner to a given problem. That's really what we are after at Fathom. And with that, I thank you very much.